Good morning, ladies and gentlemen. Welcome to Kinfon Dermatology Classroom. I would like to take this opportunity to go through the preview of my next lectures, which is on cutaneous mastocytosis in children. A lot of people has limited their impression about childhood mastocytosis to urticaria pigmentosa, and we know that this is not true because cutaneous mastocytosis has many different morphological presentation. Although I do agree that the most common presentation is urticaria pigmentosa, means that a patient walk into our clinic with multiple pigmented macule. Some are barely palpable papules of plaque lesion. When you rub the surface of the more palpable lesion, it will give you positive darocyte, means that the area become reddish, edematous and pruritus by sensation. Urticaria pigmentosa indeed is the most common form of cutaneous mastocytosis, but on the other hand, cutaneous mastocytosis has other morphological presentation, and these are some of them. It goes from single mastocytoma, multiple mastocytoma. In fact, some patients presented with diffuse cutaneous and bullous formation. So these are some of the morphology that you might encounter in a patient with cutaneous mastocytosis. The morphological presentation, it ranges from macules to papules to plaque to nodule to bullous formation. Hence, we need to have a high and broad index of suspicions. Some of you might ask, why is it so? Because the final morphological appearance is based on the density of the dermal infiltrates, the degree of the degranulation, and also basal pigmentation. Without further delay, let us take a look at the first factors, the density of the dermal infiltrate by mast cells. If you take a normal skin and stain with toluidine blue or giemsa, you'll be able to recognize about 10 plus minus 1 per high power field. We know that mast cells are normal cells in the dermis. But in urticaria pigmentosa, there's a slight increment from 20 to 30 per high power field. And in mastocytoma, you can get more than 150, a few hundreds of mast cells in per high power field. Whereas the most severe form is diffuse cutaneous mastocytosis. You can see a large area of the dermis is infiltrated by high density of mast cells. As mentioned just now, study by Garriga et al. Has shown that normal skin about 10 mast cell per high power field increased to about 150 plus minus 70 in mastocytosis. The second reason why they have different presentation is based on the concentration of the mast cell growth factors that produced by the mast cells. And these mast cell growth factors will stimulate the mast cell, basal cell melanocytes and cause basal pigmentation. And lastly is the degree of the mast cell degranulation when you examine the patient. We know when the mast cells degranulate, they release more than 20 different mediators. The well-known ones are the histamine, tryptase, and as well as platelet activating factors. This not only acting on the blood vessel, cause vasodilatation, cause increase in capillary leakage and dermal edema. At the same time, it also act on the H1, H4 receptor and induce itchy sensation, followed by recruitment of the late inflammatory cell like neutrophil and eosinophil to the site of degranulation. A slight increase in production of the mast cells mediator will induce a positive darocyte. If there is a lot of the mast cell degranulating, they may cause subepidermal blisters, which we call a bullous darocyte. If more than 50% of the mast cell release it simultaneously. Some of them will get into systemic circulation and with symptoms like syncope, flushing, abdominal pain, and anaphylaxis. So to be a better dermatologist, you need to know that urticaria pigmentosa is just one of the manifestations of childhood mastocytosis. The other manifestation including papules, nodule, and bullous formation. To know a bit more, you can visit this website www.pediatricdermatology.com.my.